We'll go ahead and get started so we don't lose too much time. But first of all, before I really open this webinar meeting up, we'd like to thank all of you for attending, but most importantly, thank you all for all you're doing to help return to screening so that the people in the United States don't suffer unnecessary cancer burden. And we know how hard it is on the front lines to deliver care in the pandemic. So it's a double difficult chore to do. So, but it's so important. We thank you for your efforts. So as mentioned, I'm Heidi Nelson. I'm joined from the cancer programs by Dr. Rachel Hsu Jung and Jessica Dangles, who works in the accreditation part of the cancer programs. We also have our collaborative team from the American Cancer Society, very important collaboration, and we couldn't do this without them. So Kelly Durden, Meg Fisher, Jesse Sanders, and Jane Smith are with us. And if we could advance the slide, please. I think you'll see that today the agenda has plenty of room for you to have questions that you have addressed. We still get some episodic questions about forms. We get questions about interventions. And we just want to make sure everybody has the best foot forward for being able to do the work in October and November before we finalize the study. So we thought it was a good time to sort of reach out and engage with everybody. So thanks for attending, and thanks to all the speakers and the participants from the programs who are going to help talk about successes and challenges. So I'm just doing the introduction. Next, you're going to hear from Dr. Jung, who's going to talk about some updates, just so you have an idea of what we know about the progress so far. Meg Fisher is going to talk a little bit about interventions. And then you'll all get to go to your favorite breakout session, whichever one suits you the most. You get a self-select, and it will be fairly straightforward and simple. We're keeping the breast group just within this group because it could exceed the capacity of a breakout room, but cervix, colon, and lung will also have breakout sessions where you have to just hit the button and go to the breakout session. So Meg Fisher, Jane Smith, Jesse Sanders, and Kelly Durden will be in the facilitators in that, with the participants who are actually doing the work of return to screening in their programs. The panel then of the facilitators will come back and talk about what we've learned in that panel. And Jessica Dangles is going to talk about some of the issues that bubble up around REDCap. And lastly, in case you want another webinar before we close out the study, we'd like to know what the topic would be. So with that, I'm going to hand it over to Dr. Jung, and she's going to give you some updates.
Thanks, Dr. Nelson. So like she said, I'm Rachel. I'm a general surgery resident at Northwestern, and I've been working with Dr. Nelson from the beginning of this project, and I'm really happy to be here, and also happy to see some faces to the names that I've communicated via email and phone. And so we're really hoping that this webinar is going to be a very informative session. So just to begin, we are all aware of why we started this project and what kind of problem we were facing before when we started. Is that Dr. Sharpless, who is the director of the NCI, had projected that there might be 10,000 additional deaths from breast and colorectal cancers alone from the missed screenings. And so we decided to offer this project to all of you guys, all of the hospitals associated with the ACS cancer programs and then the NEPBC programs to improve reduce the screening gaps. So the bar graphs, the line graphs show the fact that there was a difference in the screening that happened between 2019 and 2020. And we wanted to make sure that we were going back to our pre-pandemic rates of screening. And B was to address the screening deficits that occurred because of the year of screening that went lost. And so we put together the PDSA with the option to be involved in the clinical study, as you all are, to all of the hospitals that are accredited via COC and NAPBC. And the ACS has also, and this is a collaborative project with the American Cancer Society, who is doing the Get Screened project with hospitals to really improve screening across the United States. And we are using the ACS recommended toolkits and their evidence-guided interventions to help the programs improve their screening in their individual communities. And so we this number was reported when we had our previous webinar, but we had 749 accredited programs that enrolled in the PDSA study that resulted in over 800 independent QI projects. With the addition and with successful completion of all of these projects, we expect to see about 70,000 additional screenings per month. This slide is showing the difference of some of the targets based on the disease site. So at the top panel, you're seeing the numbers for breast, and in the green is showing that only 25% of programs had to get back to their pre-pandemic rate, and 75% had already either met their pre-pandemic rate or had a screening deficit that was less than 10%. And so we gave them the goal to improve their screening by another 10% to address the gap that address the deficits that occurred in 2020, versus in colorectal, and it aligns with the data that we saw from previously published literature, is the fact that 64% of programs had a screening gap of more than 10%. And so those institutions were tasked with improving their screening rates back to their pre-pandemic rate, and 36% had to improve their screening by another 10% to address the deficits that occurred in the previous year. And so this is just a when we initially asked you guys to fill out Form A, we asked to select some of the interventions that you had planned to start the project, and some of the more highly selected interventions were different interventions to increase the community demand by improving reminders to the patients, by utilizing small media such as social media posts or press releases, or doing patient education, including facility-wide patient outreach, and also dissemination of messaging and guidelines across the hospital systems. Also, other interventions included improving the provider delivery of screening tests by disseminating guidelines and messaging across community sites to the primary care physicians and also to the specialists. So a lot of those data are things that you have already seen from our previous webinars, from the initial baseline data we had collected. And so we wanted to give a quick status update on the data that we see so far from the Form B and C that some of you have filled out. And so on the left panel, you're seeing that some institutions are meeting their target screening test goals. And so for breast, around 40% of institutions were meeting target. For colorectal, 47% of the institutions are meeting target. For lung, 72%, and cervical, 40%. That sounds really good, since half of them, or even more than half, are meeting targets. However, on the right side, what you're seeing is the percent of data that we actually have collected. So what this means is that only 20 to 30% of our institutions that had signed up for the projects are giving us data from Form B and C. And so even though we see some patterns with our data from this interim analysis, it's hard to make any kind of a story or come up with some patterns based on the data, because our data is too incomplete. So keeping that in mind, the next few slides are some of the patterns that we are seeing with the 30% of the data that we have accrued, but we don't know whether this is the trend across all of the programs. And so for breast cancer, what you're seeing in the 3 lines is that the orange is indicating what the target is, the monthly target, and that is the median value. And the light blue is showing the monthly screenings, and the purple line is showing the number of interventions with the y-axis on the screen right side. And so you can see that in June, around in the middle of the graph, the monthly rates, the median monthly rates were going up and getting closer to target. And you can see that's when centers started doing some more interventions. July and August, you're seeing some more interventions as well, about an average of 2 interventions at each of the facilities. But still, despite doing those 2 interventions, we're not meeting the target goals. Next slide. A different pattern that we see for colorectal cancer screening is that the flat blue line this time is what's showing the target, and the interventions are shown by the light green. And so from the beginning, you could see that monthly screening volume exceeded the target. But what we're seeing in terms of the median number of interventions that are being done is that in June, around the median number of interventions were around 3 interventions, but that started going down in August. And so there's a couple of plausible theories on why we were already meeting screening targets from the beginning, and it might be the fact that we are now utilizing home-based screenings. But again, the data is too incomplete for us to say. And for lung cancer, we're seeing that also monthly screening volumes exceeded the target. But then the intervention shown in purple has declined significantly by August. And so another, a couple of plausible reasons is, are we underreporting our interventions? Are we not capturing all the interventions that all of the hospitals are doing? And so I'm going to pass it off to Meg, who is and her team, who are experts in the interventions.
Thanks so much, Rachel. A really great recap and very exciting data. So thank you for sharing that with the group. Like Dr. Nelson mentioned, our group today is going to be focusing on evidence-based and informed interventions. We've talked about this in previous webinars, but we just wanted to revisit interventions as a whole because we're seeing the trends in the data and wondering if all of the interventions are being properly captured. One thing that I would like to say just at the very beginning of this, though, that the evidence-based and informed interventions that we recommend and align with come from the community guide. If you have questions about if specific activities at your site align with this project or with the requirements of the PDSA and Quality Improvement Project, those are really questions to be answered by your Commission on Cancer counterparts and leads. So just want to state that from the very beginning that we're aligning our research with the community guide, but any clarification that you might need should be cleared with the COC. So just taking us back a little bit to the beginning of, what are EBIs and how are we discussing them and how are they generated? They come from research and from practice. And so research is, there's definitely enough data in order to determine that something is evidence-based. Evidence-informed can be derived from practice. So meaning like what you're doing now, you're running information through a PDSA cycle, you're coming out with results on the other end. There may not be enough similar research studies like yours to say that it's evidence-based and the research backs it up, but you're showing positive outcomes because you've run it through a practice component. One of the most important things when you're selecting the right interventions for your project is making sure it's the right fit. Evidence-based and informed intervention shouldn't be thought of as a menu that you just kind of select because, maybe it seems like the right fit, or, you're not quite sure what to do next. And so you want to select a new EBI. Asking yourself some really good questions about how to select the right intervention are going to lead you into what you should do next. This slide just gives you an example of how you might think about that process. So in looking at your data, or maybe where you're trending right now, maybe you're still seeing additional gaps, you're not closing the gap as fast as you thought, or maybe you're starting to trend backwards. So then it's asking yourself, okay, who do we need to get in front of? Who needs this information? Who should we be trying to reach? And that's how you look at the middle section, which is who is impacted. So is it the individual? Is it maybe your providers? Is it an organizational issue that you need to address? Is it something in your outside community? And thinking through who needs the information or the education or the reminder will help you target what strategy of intervention you want to explore. So the 3 primary strategies are increasing community demand, increasing provider delivery, and then increasing community access. So when you think about those different strategies across the different buckets, like Rachel had shared, where the most common EBIs for this project are falling, increasing community demand is really about the patient. It's educating the patient so that they're more interested in receiving screening or more educated around screening. And so it increases the demand on your system because you've done a good job of educating your community. Those are client reminders, client incentives, small media, patient education. When you're thinking about increasing provider delivery, that's really focused in-house on what you can do within your own system. And although it says provider delivery, that's really all providers, anyone who interfaces with a patient. That's clinic staff at all levels, that's administrative staff, navigation, higher level administration, and that's really upping their knowledge base about what you're trying to do. Sometimes we tend to focus externally on our patients, and then we disproportionately increase community demand, not at the same rate as provider delivery. So we have a lot of people coming in to get screened, but the providers haven't been given the same education. And so there's a disconnect a little bit about what you're sharing externally as well as internally. So when you think about increasing provider delivery, that's really what you're doing within your own system or your own clinic to make sure that you're prepared for the demand that you're creating. And then increasing community access. And that's really about reducing those barriers that exist that are truly preventing people from coming in for screening. It's less about education and more about structural barriers. Maybe the items are not in the right language for them to consume the information. Maybe the hours don't align with what works for their work schedules or childcare schedules. Maybe there's an expense associated with this screening and a copay is just something that they're not able to handle at this time. The most important thing about this slide, though, is to be most effective, you're not going vertically, you want to look horizontally. So if you're looking to up your interventions, don't try and do, okay, we want to do everything and increase community demand. The biggest bang for your buck is to say, we want to pick something from community demand, provider delivery, and then community access. That's where you'll have the most effectiveness because now you're hitting and solving the problem from a variety of fronts and you're not solely focused on one area and discounting or not focusing enough on others. So that's really the main takeaway when you're thinking about the different strategies. And there are percentages associated with this of having better outcomes. The most important thing is look across when you're picking your strategies. What we're going to do today and how we're going to spend a lot of our time is for you to have meaningful conversations with each other. The Commission on Cancer hand-selected a few participants in this project to share their best practices, some of their early wins, maybe some of their challenges, and have aligned that with the language of evidence-based and informed interventions. So you can really hear what it sounds like when someone is performing an EBI and what that might look like in practice. We hope that this will help next time you're completing your REDCap form. If there are items that you're not capturing or things that you haven't translated yet, that you're making sure to document that. Again, always reaching out to your COC counterpart if you have questions about what counts and what doesn't. But that's really the intent of the breakout room. So we encourage you to be interactive. We'll be starting with short overviews from our presenters about what they've done. We'll have ACS facilitators in those rooms who are going to help guide the conversation. There's quite a few of you on the call today. We're going to ask that you use the chat feature in your room and also raise your hand if you'd like to come off mute and contribute to the conversation. For those of you who haven't used Zoom a ton, if you want to raise your hand in the bottom right of your menu at the bottom of the screen, you see reactions. There's a hand raised there. That'll alert the facilitator that somebody would like to come off mute and speak. But otherwise, feel free to put things in the chat. Our facilitators will be watching that as well. Dr. Nelson, any points of clarification or anything you'd like to add before we go to the breakout rooms?
No, I think I've gotten a few chat questions. Keep the chat questions coming, and we'll try to pull them right back into the panel at the end. But I think we've set up the story perfectly for the breakouts. Hope everybody has a good time. We'll come back afterwards and sort of summarize through the facilitators what we've learned and how we can go forward. Thanks so much.
Yeah. So just a reminder, if you're most interested in breast, you're going to stay in this room. So you don't need to select a breakout room. Deborah, next slide. If you are going to a breakout room, and Megan, if you could open the breakout rooms, you'll see a little pop-up at the bottom of your screen that mirrors what's on the screen now. It'll show you that you're able to now join a breakout room, and you can select lung, cervix, or colon based on your area of focus or what you're most interested in. So we'll give everybody a couple minutes to find that and then navigate themselves out of the main room. With the exception of breast, you all are staying here with me in the main room. So with that said, I am going to open up my list of our presenters here today. And how we're going to get started is just having them share a bit about their experience thus far, what they've done, and then it'll help hopefully generate some questions for you. If you do have questions, go ahead and put them in the chat and we'll address them as we go. Nicole's going to be helping me with monitoring what's going on in the chat and also kind of keeping notes on what we learn while we're here. So Angie, if you wouldn't mind taking yourself off mute and starting just by letting us know who you are, where you're from, and a little bit of an overview of your project.
Yes, ma'am. My name is Angie Caton. I'm a nurse that works at Northeast Georgia Medical Center in Gainesville, Georgia. Well, since COVID, I can't really give you exactly how many beds we are. Yeah, about 800 between the 3 campuses, 600, 200, and then the others, come and go. Anyway, our breast screening project, we've been really excited. We are meeting our goals and exceeding our goals for the 10%. We were maybe, as was mentioned in the earlier presentation, we are one of the facilities that had higher pandemic screenings than we did in 2019. So 2020, we saw an increase in screenings. We did have a dip, but we rebounded and came back. So our pandemic, our screening rates, we picked, there's 10% of that pandemic rate actually, and not the pre-pandemic rate. So, and we're talking about 2,300 mammograms a month is our goal. 2,394, I believe, is our goal. And one of the best things, and again, I mentioned this, one of the best things that we've done is engage, I've encouraged, and it's been very successful, is engage our GME. We're a brand new GME resident program, and 2 of our internal medicine residents have been extremely engaged and interactive in this project, along with one of our breast surgeons. So what's been real effective is patient reminders. And so my 2 physicians, residents, engaged internal med and family practice doctors to review lists weekly, and their offices are making contact with the patients that are behind on their mammograms. For patient education, we've attended several community events and spoken at those events. We also set up a website with a way for individuals to ask questions, or maybe if they didn't have insurance, and those forms come directly to me, and then I help navigate the patient. And I would say, although it sounds like a really good idea, that this would probably be the one that probably took a lot of time on our public relations staff's time, but it hasn't. I've only received 5 requests for information, and then I have only made contact with 1. I keep calling and have had difficulty finding the other 4. So I was saying it sounded like a good idea, and we're talking about that PDSA cycle. I don't know that would be an intervention that we would continue. We seem to have gotten a lot of bang for our buck with media. We've had postcards developed with guideline and messaging for patients. Partnership with our indigent clinic, one of our local indigent clinic, to get messages across. And how we did that was that we recorded physicians, and we tried to get, because we're in the breast cancer project, we tried to get female physicians to speak these messages of the importance of screening or returning to screening in Russian, Arabic, Vietnamese, Spanish, German, and Ukrainian. So we had those recorded and translated into print, and we've used those on Facebook. And then we've also provided that to our indigent clinic folks because they have a large number of people that do not speak English or English is their second language. We've also been on the radio, 2 different programs on the radio that I thought was very successful. And one of our physicians, Dr. Fidel, residents, she did one and I did the other. Provider awareness, the internal meds, again, the internal meds and the family practices, our physicians have been really active in keeping them aware of the guidelines and then what we were doing. Provider reminders and recalls. We got a report generated from our EMR. We have an Epic EMR, and so it will run a report. And it is, first time I ran it, there was like 10,000 on it, and so we had to do a lot of refining on it because it didn't seem to be pulling correctly. So we have that, and the residents have access to that too. So that helps them.
Awesome.
And then lastly, the provider, I got a couple of I'm hurrying. Provider assessment and feedback. Our residents are keeping a spreadsheet on all the doctors, so they know what their screening rates are, and they're reporting it monthly to our internal med and our family practice. And then community access, our interventions to reduce barriers. We've collaborated with the local clinic to help provide some funding for some more mammograms and to help provide more materials for them. Structural barriers. So every month I touch base with the imaging director and make sure we have capacity and let her know what the numbers were from the month before. And, so that we have enough staff and enough availability for exam appointments, especially with the recent surge in COVID. There's been a lot of staffing issues in our hospital system. And then gift cards for those indigent patients. We have $120 gift cards for the first 100 people at our indigent clinic that complete their mammograms. And that's going very well also because I've worked on other projects in our community, and that is a big help to get some of our patients to where they need to be so that they can use a lot of them take cabs, and a lot of them use other forms of transportation, do not have cars. And so that helps them offset expenses. But I think we are going along very well. And I'm excited to see what our September numbers are.
Yeah, you guys are ticking a lot of those boxes. I loved
Yes,
hearing
ma'am.
too about how you're reporting back those numbers. So they don't just live in a spreadsheet, they become a living
Right.
document that people reference. That's great. Melissa, I'd like to pivot over to you next. I know in our conversations, you're also seeing some increase, and you've done a lot with sharing information with your staff as well as getting things out on social media. Can you talk a little bit more about what you all are doing in your system?
First of all, Angie, that sounds amazing. And I just took down some notes. So thanks for the ideas. So far I'm excited because we seem to be doing really well and seeing numbers increase, which is great. So we've done a lot with social media and staff and patient outreach so far. We started with Facebook posts. We're working closely with community relations, radiology, and a breast surgeon to get the word out as much as we can. Excuse me, I hope you can all hear me. Community relations has been wonderful, created an image kind of for a campaign. So we're using the same image across different platforms, hoping people will recognize it and really think of that as mammogram awareness. So we've used it on different Facebook posts. We did that just prior to June 1. We did another in August. In July, we used something what we call as a hearing now, which is something that goes out to every staff member of Good Samaritan Medical Center where I work in Brockton, Massachusetts. So that's good for provider education, staff education, but also a lot of our patients or staff members. So we figured that it was really good bang for our buck to get it out that way. And I believe it goes out to about 1,500 people. Then we continue to do more Facebook posts. The other thing we've done is with our breast surgeon, we're utilizing Facebook as much as we can, and she's done some live videos, one to introduce herself because she's pretty new, and then also she's done different clips that I heard yesterday were just finalized for the importance of mammograms. So they're going to be released most likely weekly during Breast Cancer Awareness Month as part of the campaign. And then other things set for October are I will be actually going out to a farmer's market in downtown Brockton, so the city that we're in, to try to reach people that may not see things on Facebook. And I'm actually a dietitian here, but I do a lot of the COC stuff. And so I'm going to be bringing information on healthy nutrition, for cancer prevention, but then also being side by side with a lot of information of how to get your mammogram, how to make appointments, tips on transportation, that kind of thing. And then the next intervention we have planned is a mass email to patients with links for how to call to schedule their mammograms. So that's about it.
Great. Thank you, Melissa. I appreciate you sharing all of that. Sounds like you guys have been very busy as well. And I know everyone's gearing up for October for Breast Cancer Awareness Month.
Yep.
Jennifer, if it's okay, I'd like to go to you next and talk a little bit about your collaboration with local community clinics and what you've been able to do there. I thought that was a really unique approach and something that we haven't heard yet.
Okay, hi, my name is Jennifer Brown. I'm actually a cancer registrar here at Riverside Health System. We are a collaboration of 4 acute care hospitals, one of which is NAPBC accredited, and that's why we're doing the breast intervention. We are also COC accredited, and we're doing the cervical intervention for that PDSA. But today I want to talk to you about what we've done for breast cancer. Very much like Angie, we found ourselves, our pandemic rates were higher than our pre-pandemic rates. We attributed that to some of the other diagnostic centers in our area did close and they were not doing any screening. So we may have had this influx of patients that otherwise may have chosen another healthcare organization to get their mammogram with. But they came, they got their mammogram, and that has allowed us to have a benchmark of about 3,000 screens a month that we're trying to achieve. It is a high number. I'm glad that we did achieve it last month, and I hope that we continue to reach it. Part of the way we have been able to reach so many patients is through our partnership with free clinics. Our community outreach coordinator for the COC, she goes out into free clinics, and in the area we have a few that we partner with, and they will actually interview and register patients to enroll in either the Every Woman's Life program or a Komen grant if they are eligible to get screening that way. So we're trying to overcome some of those barriers. Now, in the beginning, we weren't able to get our outreach coordinator into free clinics. So since that has been allowed, it's really helped us out. Now, future challenges might be if these clinics close again. I feel like with the state of COVID and variants, and it feels like we aren't really sure what's going to happen month to month sometimes. So, but we're still getting out there screening. We've also, like some of the others, we have Epic. I think a lot of people have Epic. Any patient that had MyChart, there was an automatic push if that patient was eligible, and it would push a notification if they were signed up on MyChart, and they could then click a link and automatically schedule their appointment. Mm-hmm. They didn't have to call anybody. They could do it right there from their tablet, computer, phone, any electronic device that had my chart.
I love that. I think that that's such a time saver for
Yeah.
patients, and really nice. I know I've taken advantage of scheduling my
Mhm.
mammogram when it was just like, just click here.
Yeah.
Just in the interest of time, because we just have a couple minutes left, I just wanted to pivot over to Teresa. And Teresa, if you're able to take yourself off mute. One of the things that you talked about that I thought was really innovative was just how well you're tracking what you're doing with these interventions to see what's really successful. Are you able to give us a couple minute highlight of that?
Yeah, so my name is Teresa Schutz, and I am the breast health coordinator with the Renown Health System here in Reno, Nevada. And we created a sort of survey that the patients fill out while they're completing their mammo questionnaire. It's just a little snippet right at the bottom that just asks them, thank you for coming back in for your screening. What brought you in today? And they're allowed to do, or they're able to check off boxes as what it was that brought them in. One of the most interesting ones that we've seen is patients are in because family members or close friends have recently been diagnosed with cancer or with breast cancer, or they had a scare, and that's what's really driven them to come in for these screenings. So that was really interesting to see, but it's been really, really great to have that because we can see which ones are more successful. So we're able to see that our social media has been a really popular source of getting our patients in. So we're really hounding our our media department. We were able to really track which ones were working and which ones maybe weren't great, so we could amp up those areas as well. So we were able to create just a little survey that they just fill out while they're filling out their other paperwork with us.
Thanks, Teresa. I loved that when you shared that yesterday, to really make sure with all the things that you're doing, what are some really unique ways that you're able to track what's been most successful. We have just about 1 minute and 30 seconds left before we have some people entering back into the room. Nicole, I wanted to check in with you and just see, was there anything that you wanted to share that was going on in the chat, or things that maybe we want to address before we end?
Sure, Meg. There's a couple of questions around documentation and if they should be documenting elsewhere or on the breast cancer sheet that they have, around documenting and tracking interventions monthly. Do they need to do that? So should we refer them back, or is that something that we can answer?
Yeah, I would strongly suggest that you reach out to the COC if you're having questions about documentation, where specifically, of course, in addition to those REDCap forms, you'll want to handle your own documentation to upload into the SAR when it's time for your survey. But if you have additional questions about that and need some clarity, I would strongly suggest that the COC answer those so that you're getting what's in alignment with how they're going to survey this project.
Perfect. Thanks, Meg. And then for everyone on the call, I added two resource links in the chat. So if you want to bookmark those, there's a really nice interventions document that we have, and how to implement them and what population they are best for. So
perfect. Thank you so much. All right. Well, we're going to jump right into it. I'm really curious. Obviously, I facilitated the breast cancer group, and we had a really large, very interactive group. They had lots of great questions. But I'd like to start off, Kelly, you were in the lung group. Can you just tell us a little bit about what you learned there, or some of the more interesting interventions that were mentioned?
Sure. So first, our two individuals were just fantastic. I think we all could have spent another hour just listening to some of the amazing work that they were leading. Some of the common themes, though, were around the importance of building a multidisciplinary team, the importance of navigation, the importance of provider engagement and clinician education, and then around just provider assessment and really the provider recall system. There was a lot of talk around the importance of tracking and EHR systems, which is incredibly important for all screening, but definitely most important for lung cancer screening, just given the complex eligibility.
Yeah, absolutely. And Kelly, from your perspective, I know we would consider you at ACS a subject matter expert in the area of lung cancer screening.
Definitely not. I just work with experts.
Can you talk to us a little bit about the nuance around lung cancer screening when we use the term evidence-based intervention, and how far we're able to take that term and where we're not able to go because of the research limitations that exist?
Yeah, so I've been taught and recommended that we say evidence informed, right? Because we don't have anything strongly yet within the community guide. But a lot of the tools and a lot of the things that we all know are really the same in terms of the importance of provider engagement, finding that champion, clinical education, the EHR aspect of it. So, but that's really as far as I would go in saying it. And I'm quoting the great Robert Smith, who serves as our SVP of cancer screening at the American Cancer Society.
Great. Thank you for that context. That's really helpful. Jane, let's switch over to you and get a little bit of feedback from your group and what you learned. You were leading the cervical cancer group.
Yes, and we had a great discussion, and I really want to commend Jonathan. He was a fantastic speaker and gave a really great overview of what him and his health system have been doing, and they're doing amazing work. And when Meg showed the columns that from before we went into breakout rooms, I can definitely see where Jonathan and his team are touching all three of those columns and doing the horizontal work that needs to be done. And I just really loved the messaging too, and the motivation for wanting to do, focus efforts in women's health, particularly. They really rooted this in with during COVID. Many women are not thinking about taking care of themselves because they're often taking care of others. And so reflecting this back on how to take care of yourself and really using messaging around self-love and self-care was really special. So they are doing all different kinds of interventions, from provider education to patient education, as well as small media. And then it has blossomed into this beautiful gift, which Jonathan was highlighting, that they've created a women's assistance fund to help reduce community barriers to seeking cancer screening care. So it's really great how the interventions that they've put in place have continued to blossom into future interventions to help get women the cancer screenings that they need.
I love that. And I had the opportunity to talk to Jonathan yesterday and was also equally intrigued by the way that they're approaching the messaging. And I think that that's a really good point. One thing that women tend to do, like you said, is put themselves on the back burner because they're taking care of their communities or taking care of their families. Not to say that the dads and gentlemen in the communities don't do that as well. But a lot of times the barrier tends to be childcare. Especially for women who may be single mothers. And I heard through a few of the examples and through some of the work that we've done is that partnering with faith communities where they have on-site childcare is a nice way to kind of bridge your community and create and tap into that support system that exists for women. So they can go after service. Their kids can stay in the church daycare, and then they can go and get their routine screenings, which I thought was just a really nice way to show a supportive community for women.
Definitely. Yeah, it's incredible to see the innovative approaches that folks are taking to get around some of these issues to screening.
Yeah, absolutely. Jesse, let's have you join us up here in our virtual panel and talk a little bit about what was going on in the colorectal cancer screening room.
Sure. So as Jane mentioned, our first speaker, Deborah, and again, thank you to both of the speakers in our colon group. Deborah talked about really kind of those different buckets that Meg had mentioned, not working just in one bucket, but really going across the board and trying a few different things out at once, which we know increasing, the interventions that you're doing is going to increase the screening rate. So they really did a great job at looking at those rates from 2019. So really getting a clear picture of what was and comparing it to what was happening in 2020. And then they made sure that that wasn't just something that they were looking at, but they were sharing that with their teams. So they did do that provider assessment and feedback, EBI, which we know, making sure to, include those rates with those individuals and letting them know how they're doing and being consistent about that so they can see progress and they can see changes in those rates really encourages them to continue the work that they're doing. So they, updated some things in their EMR. They did client reminders. They did direct calls to their patients, which I think really makes a huge difference in confidence for those patients to make them feel comfortable to come back in or to complete those screenings. And then they also did one-on-one education when they did those calls. They actually had, folks talking about the different options and really providing, again, that confidence that helps patients in the world that we live in right now feel more comfortable getting the care that they need.
That's
and then
great.
Yeah. And then Tiffany also shared, and she's at Centricare in Minnesota. She shared actually a totally different approach, but equally amazing in building that confidence in the community. Again, we saw, I mean, all last year, we heard a lot from our partners, I think at ACS, that there was lack of confidence in going back into healthcare because people were scared. They didn't want to go back in, they were scared. And Tiffany shared how they used social media, they used a lot of digital platforms, they used direct mail to their patients as well, and interpreted those into Somali and Spanish for those patient populations to build that confidence back up, to get back into the system. I can't even say everything that they did because it was amazing, all of the different avenues they utilized to try to get the word out that it was safe to return to care. We want you to come back in. And this was not only for public education and for their patients, but it went, you know, it was in front of all of their medical staff as well. So everybody was on the same page, hearing the same message in a multitude of ways, which again, I think only builds that confidence that yes, it's time to get back in and return to care.
Fantastic. You know, and I love something you said, Jessie, about making sure that the information on the patient and the provider side doesn't just exist in a spreadsheet that no one ever uses to kind of see their progress. All of us love to see how well we track towards our goals. That's why we all wear Fitbits and Apple Watches. Closing those rings means, you know, something very important to everybody. And I think sharing that and that provider feedback is so critical because people don't know how they're doing unless they can really track those in real numbers. And so I thought that was a really great insight that came out of your group of just how focused they are on that and the great ways that they're consistently sharing that information.
Absolutely. We had a great group. Thanks again for those who shared.
Yeah. And I'm going to actually ask Nicole to join us up here as well. You guys have heard quite a bit from me today. So Nicole was with me in the breast cancer group, and I'd love for her to share a little bit about what we learned and heard, and maybe something that we haven't heard from the other panelists.
Sure. So thanks, Meg. So we had 4 very terrific presentations from our partners here. And what my takeaways would be, they have very solid plans of actions to move forward. They have really nice laid out goals. They have multiple champions inside their systems, and they're all collaborating internally and externally with community partners. So a few of them have multiple interventions ongoing at once. And then a couple of them offered insight into the communities that they serve and really went into the community and have plans to go into the community to reduce structural barriers, whether if it's financial, transportation, there's education happening in the communities. They're translating materials into different languages. They're implementing small media campaigns so that there's some robust work going on in the breast group. So great job, everybody.
Fantastic. Yeah, it was a really great conversation. I loved getting the chance to talk to everybody yesterday and hear it again today. It was really wonderful. One thing that I just wanted to address as we're talking about evidence-based and informed interventions and kind of how we bucket them and think about them, they're really generated from the community guide, but not meant to be limiting or not meant to be the only ways that you can approach these problems, although it tends to be where we focus during these calls just to make sure that they're very clear. In your forms that you have to complete for the COC, there is the option to select other. So if you're doing something innovative or something that doesn't fit very cleanly into one of these categories, please make sure to document that because it could become a best practice and is likely a really strong intervention. So I just want to make sure that no one feels limited with the way that we're talking about it. It's just sometimes helpful to have some additional context. Thank you, ladies, so much for your time today and for all of our presenters. Deborah, if you're able to pull the slides back up, I just wanted to cover a couple resources before I turn the stage back over to Jessica to close us out. And while Deborah's pulling up the slides, I will just give you a little bit of a preview. So yeah, just next slide after that one. There are some additional resources to help you navigate the community guide because sometimes when you go in there, it's just a lot of information that you're trying to weed through to find out, you know, what am I actually looking at here? What are some simple definitions? Can you break it down for me? So we've created this through the American Cancer Society, but really it's pretty much heavily influenced by the community guide. We're not taking any liberties here. To give you a really at a glance, here are the different interventions. Here, who are they're appropriate for, what screening site. And then on the flip side of each page, so it's 6 pages long, there are brief descriptions and some ideas or suggestions. If you're wondering, what interventions am I doing, or is this client reminder and recall, or is this patient education, and what's really the difference? So I wanted to make sure that you're aware that this resource exists. When this deck is shared, this resource is linked on this page, so you can access it there. Deborah, next slide, please. And then there's just another listing of resources. So if you want to explore what else is out there or get some additional feedback or information, I strongly encourage you to take a look at this resource list and see what suggestions others have had, how people have approached a similar problem. Also, if you look at the resource, the very last one on the page, the Evidence-Based Cancer Control Programs website, that actually translates what's in the community guide, those interventions, and talks about them in practice. So gives more case examples of what did this look like. It's fully searchable, so you can search by intervention, by cancer type, and you can pull up all of the other articles and read what others across the country have done. It's very, very interesting, very rich data. So I would encourage you to look at that as well. And with that, I think we're on time to pass it over to Jessica. Thank you all.
Thank you, Meg. Deborah, if you want to go to the next slide. So I'm going to spend just a little bit of time today talking about the REDCap forms. We have received a lot of questions on how to fill out the forms or not receiving the forms. And I wanted to go through just a few of the common questions that we've received. The most common question we've received is, why did I not receive Form BC? And just to let everyone know, the emails are all coming from redcap@facs.org. So be sure to check your spam and your junk email. We know a lot of hospital systems block certain email addresses. And then the Form A contact email needs to be updated. Whoever is on your Form A as your point of contact is receiving all of your emails from REDCap. So if that person's no longer in their role or they've moved, you do need to update Form A, and I'll walk you through how to do that. And then how is Form A different than Form BC? Form A is where you entered your pre and your pandemic screening data. That information was entered back in June, and that form is now closed. Form BC, this form is one form, and it contains your ongoing screening data and your interventions. And we really want to reiterate on this call that we are encouraging you to enter your monthly data. Every single month, we want you going into Form BC and inputting your data. And then finally, what do I do if my contact person has changed? Because Form A did close back in June, you will need to send me an email. So my email is on the slide deck, and we will be sharing the slide deck with you. So you'll need to send me an email along with your disease site, and I can update your contact information in Form A. Deborah, if you could go to the next slide. So taking a look at Form A, just as a reminder, once again, the email contact listed on Form A must be current. So Form BC was sent to whoever's email address is on Form A. So it's not your PI, it is your email of the individual completing this form. It's an easy update to make, but I will need to update that form for you. Next slide. And once again, on Form A, this contains your screening data and your monthly screening target. So what I've highlighted here are your pre and your pandemic rates, along with your goal for your screening target. Next slide. And then taking a look at Form BC, be sure to familiarize yourself with the instructions on Form BC. We do state on here that we encourage you and really want you to go in and save your answers every single month by clicking that Save and Return Later button at the bottom of the form. So we really want you to bookmark Form BC and go in every single month and update your data. Next slide. And just breaking down Form BC, this is Form B, and that's what's used to monitor and record your monthly screening rates from April 1st through November 30th, 2021. If you haven't gone in and inputted your numbers, you can do that at any time, but we really just want you to stay on track and enter in your numbers every single month. And I will say this numerous times, but there is a Save and Return Later button at the bottom of the form that we are encouraging to use every month. Next slide. And then Form C, which is part of Form BC, this is your activity tracker, and this is where you're keeping a log of interventions. So I know Meg's team has shared a lot of information on what's considered an intervention. So please enter these in every single month, document the number of interventions implemented during the month. And I'll say it one more time, but save and return later at the bottom of the form. So the next month you can go in and start the following month of data. And then next slide. And just some final reminders, if you do need to update your contact information on Form A, or if you still can't locate Form BC, please send me an email. I will need to search by whoever filled out that initial Form A. And then if you could include the disease site, I can definitely find that information for you. And finally, use the save and return later button on the bottom of the form. And please go in every single month and bookmark that form for easy access. Next slide. And now we are going to have a poll appear on the screen. Chantel, if you could have that poll pop up. We'd like to learn more about what kind of topics you'd like on a future webinar.
It is not letting me launch it. So can someone else, one of the other co-hosts, launch it? Yeah, can you guys hear me? It's not letting me launch it. So,
I see it.
Okay.
Yep. Yeah, it's launched. People are responding.
We've got
okay.
about 50% of our participants that have responded thus far. So we'll give it just about another minute before we wrap up.
Can we show it, or we can't show it until it's completed?
I think only the participants can see. It looks like the most popular is what documentation is required for compliance with the standards. That is by far the highest, followed by what activities are required for compliance with the standards. So looks like that may be a future webinar topic. We've got about 75% that have participated. I think maybe in the interest of time, I will just go ahead and end the poll. I think we've got a clear idea on what everyone is looking for on the next webinar. So thank you to everyone for joining us on the webinar today. Dr. Nelson, I'm not sure if you have anything else to add, but we do want everyone to fill out a short survey before closing your browser.
Thanks to the participants, the speakers, the panels, our colleagues at the American Cancer Society, and all of you for the work you're doing. Thanks so much. This was recorded. Slides will be available. Take care. Enjoy the rest of the day.